Bonjour tout le monde. Can I ask those of you in the back of the room to join us? Come and take a seat in the front, because you won't be able to see anything otherwise. This is such a huge room. I made the mistake of sitting at the back table on the first session, and I tried putting on my glasses and realized reading glasses don't help at all in that situation. It's terrible. Alors, bonjour tout le monde, à toutes et à tous. Mon nom est Don Shepard. Je suis le vice-président de la Direction générale des programmes sur les maladies infectieuses et de la vaccination à l'Agence Santé publique du Canada. And I really look forward to the day when I have a job that I can say in less than 3 minutes, but that's not it. So, the brave ones among you that have joined us this morning, a rainy Sunday morning, the last symposium, we thank you for your dedication. We really appreciate that you're here, and we're going to have a great session for you. I promise. All right. Before we begin, let's take care of things that we need to take care of. So the most important thing, I think, is to do our land acknowledgement and recognize that the land we're holding this session on today is the traditional lands of the Huron-Wendat nations. And we come from all over the place. I come from the Anishinaabe territory, so I'd like us all to take a second, pause, and just be a little bit grateful for the lands that we work, play, and live on every day. And then beyond the land acknowledgement, I want to do another one that's not in my speaking notes, but that I've been inspired by in my time I've been here at the conference. And that is, I want to acknowledge the Indigenous voices I've heard at this meeting. The researchers, the community educators and activists, and the people living with HIV. Your leadership here has been inspiring. It's moved me, I've learned, and I look forward to continuing to learn. Thank you. So before we start, I want to address the elephant in the room. I'm new to the Public Health Agency. I've been in this job a whole 4 weeks, and I have been trying to solve the greatest mystery of public health in Canada. And that is it PHAC or FAC? And 4 weeks of deep and intensive learning has taught me that I have no idea. Et pour mes amis francophones, je sais pas quoi faire avec HIVST. Donc c'est l'agence, ça marche. More seriously though, this has been a great conference for me. I started in HIV many years ago in San Francisco back in the days before antiretroviral therapy. And to see where we've come from those days is very much inspiring. It's very exciting. But at the same token, it's a little sobering because some of the conversations we had in those days we're still having today. Stigma, discrimination, lack of access, equity, they're all still there, and these are the challenges we're dealing with every day. And as the title of our symposium would suggest, we need to innovate the heck out of those problems. That's the only way we're going to solve them. We're not going to solve them by doing what we've been doing for the last 40 years. So let's talk innovation. Let's talk innovation and challenges, and let me frame this around the famous 90-90-90 or 95-95-95 where we'd like to go, or 100-100-100 where I personally would love to see us. So if we talk about our first 90, that's detection, of course. We've got some innovation there. We have the self-testing and community testing, decentralized testing initiatives. The government of Canada is very proud to have supported these. I have numbers, something in the range of $12 million that the agency has committed to purchasing self-tests and distributing them to community organizations. Many of these people I've met at the conference, as well as testing in communities in rural and northern areas. So testing is great, but testing is an opportunity, not just to diagnose people, but to link them to care. And for people who test negative, to link them to other behavioral interventions or things like PrEP to modify their chances and keep them where they are in the negative space, preventing new infections, which is our real goal, right? No new infections by 2030. So that brings us to the second 90, the people who are on therapy and who are receiving treatment. Well, we didn't quite make that target, right? We're at 87, I think, is the last number I saw, not 90, which tells us that we have a gap there. And I've heard that over and over again from stakeholders at this meeting. Access to care, access to the care continuum, access to therapies is a big barrier. We need new solutions there. Many of you are working on them, and I've heard some incredible creative ideas, but that's where we need more work. And then, of course, the last 90, we move into undetectable. And that brings us to our U equals U message. We've got great therapies now. I mean, I remember the first patient I put on triple therapy and seeing the magic of how the disease evolved. But there's still room for more innovation in there, better drugs, longer acting, less side effects, dealing with resistance, all the things that we've discussed at this meeting. But I think more importantly, that U equals U message is really powerful in some ways to combat stigma, but it's got that hidden flaw of privilege. Because if you don't have access to the medications to become undetectable, this is a bit of a slap in the face, and we need to recognize that. So, some good things, but some really sticky challenges. The good news is, they're going to give us the answers. No pressure. We have some different voices from different communities that are going to give us their perspectives on how innovation can help us get solutions to specific communities. And so to walk us through this, I'm fortunate to have Dave Miller with me here today. So Dave is a community educator from Halifax, Nova Scotia, and a Micmac HIV activist who's worked with many, many community organizations, including the Reach Nexus. And he's going to walk us through, keep us on time, and get us those deep insights that we're all here for. So I'll close just by thanking you again on behalf of the agency, on behalf of myself, quite frankly, for joining us this morning, particularly those of you that might have been at the gala late and might have overindulged and are sitting here feeling a little woozy. Drink up your coffee, and we'll try and keep you awake, interested, and excited. Over to you, sir.
Thank you, Don. Thanks, Don. I just want to say one really quick thing before we get going here. We've got a great lineup of panelists here. But I wanted to, something happened this morning. I had a thought when I was getting ready that I was doing a lot of whining the last couple of days about getting old. But I got to thank everybody in this room, the doctors, the activists, the ACOs, everybody for, I went, wow, I'm getting old. But something clicked today and I went, I'm getting old. And so I owe that to everybody in here. We're going to dive right into it this morning. We've got a great lineup of panelists here. We're going to go along and let each one introduce themselves, and then we're going to get started.
Good morning, everyone. My name is Alex Mustin, and I'm with the University of Ottawa and work on Get a Kit, which is a nurse-led project to distribute HIV self-tests.
Hi, everybody. Bonjour tout le monde. My name is Daryl Tan. I'm an infectious diseases physician and a clinician scientist at St. Michael's Hospital in Toronto, and a lot of interest in AST/BBI's prevention and treatment.
Good morning, everyone. Good morning, everyone. My name is Emmanuela Ojukwu, and I am an assistant professor of nursing at the University of British Columbia. And my research focuses on women's health and HIV/AIDS, also look at racial and gender-based health disparities and inequities.
Good morning. Bonjour, Annie. My name is Christian Hoy. I'm a person living with HIV and also a senior global community advisor at Prevention Access Campaign. I'm based on the Dishworth-Montespoon territory, also known as Toronto, Canada. Thank you.
That's great. And so, Dr. Emmanuela, this is your first question. Many factors influence communities' access to health and social services, but one of the largest systemic barriers is stigma and discrimination. How do we support the dismantling of stigmatization and on the basis of HIV status, race, sex, gender, and other aspects of identity within our prevention and linkage retention to care efforts?
Thank you for that question. It is so loaded, and I thank you for having the faith in me, for having the one answer to this. I think that there are several efforts and several things that can be done to help with destigmatization of various sets of people. It requires individual and systemic level efforts as well. Should be multifaceted. I think that the first thing that we can start with is education and awareness. So educating people on the ills of stigmatization and raising that sort of awareness. Also education on just HIV transmission, prevention and treatment strategies can help with reducing stigma related to HIV. Another thing is recognizing the impacts of intersectionality, right? Because even within just communities that share a positive network community, racism can still persist, sexism can still persist, homophobia, transphobia. So as a physician, as a healthcare provider, as an activist, as a community leader, that in your dealings with people, just realizing what level or how deeply the intersections that they face in terms of their marginalized identities can influence their health outcomes. I was a panelist on the CAHR, a special section on Thursday, and one of the audience members, I don't know if she's here right now, but she said something that really stuck with me, and she's a pharmacist. She talks about social prescription, right? So as providers, we stay so focused on prescribing medications and focused on symptomology, and forgetting, just spending the extra 5 minutes to ask how everything is going, right? Like, you could tell them to take their medication and take their medication all you want, but if they don't have food at home, if they have several mouths to feed, if they don't even have the age, if they don't have access to care, all of those things can influence whatever advice you're giving them in terms of managing their symptomology. We can also help by, one other thing that we can do is like empowerment through community-led initiatives. Empowerment can be from an individual level, it can also be at an interpersonal level, and it can also be at a systemic level, right? I always say that at the individual level, racism does two things to you, or one of two things to you. It either makes you like overly sensitive to the very little thing that happens to you. You start to overthink things. Did they treat me this way because of my skin color? Like, what is going on? You start to overthink things and start to connect dots that weren't even there. Or at the other extreme end, it can make you grow a tough skin to things that you become desensitized, the things that you actually should be sensitive to and speak up about and against, right? So knowing when to speak up, knowing when to walk away, knowing when to provide education, knowing when to ask those questions, but not in a confrontational or aggressive way. Oh, I noticed you did this, like, is there a reason? For example, I was taking a train from one point to another point, I probably should not disclose, and the public officer was going through the aisle. You know how they do like the checks for your tickets. And so I am sitting in a corner with, like, there are 4 of us, right? There are 2 blacks and 2 whites sitting opposite each other. She walks into our corner and she asks me for my ticket and asks the other black lady sitting next to me. And as she's making the move to step out, I was like, oh, excuse me. I just noticed, were you only asking like specific people in the train for their tickets, right? And she said, she looks me straight in the eyes for like 5 seconds, and I'm looking back at her, I'm like, I mean, it's an innocent question. She looks to the white folks and they're like, don't look at us, we don't know, answer the lady, you know, like. So she said, oh, I was going to ask them too. I said, oh, okay, because it just looked like you were about walking away. So she begins to ask everybody else on the train, every single person for their ticket, right? So asking those sort of questions in ways that are like very polite. You're not trying to start a hashtag to make somebody lose their job, you know, like you're being respectful, you're being polite. But some of those, asking those sort of questions can help the person reflect, even check themselves. They might not even realize that the things that they're doing are perceived in that manner. In terms of also empowerment, empowerment for community-led initiatives, we can help like at the systemic level. We can help like, we can have dedicated funds to help with the development of community-led organizations. I am part of an organization called the Black HIV Manifesto, and we're a group of researchers, community leaders, or people living with HIV who were very committed to this work. And it's all spurred from the fact that like the black community living with HIV, they're very disproportionately affected in terms of testing, diagnosis, and even treatment, right? I remember like wanting to update some of my literature review in terms of statistics on HIV for black women. And I visited the PHAC website, and there wasn't information on specific to black women in terms of the HIV care cascade. There was information on like racialized groups, and you know, grouping all of these groups together doesn't help with focusing that attention and showing the distinctive like differences or experiences of stigmatization that they all experience. They could also be in terms of things that we could do in terms of reducing stigma. The funding can also help with like research to make this data available. It could also be funding to help to develop this community organization. So local social support groups need funds to be functional, right? In my research with interviewing ACB women living with HIV, I can tell you a number of times that women like were happy or felt like wanted to engage in care because of the support that they received from their local support group, whether it was a food drive or, just like the government gave us a little fund, let's go like buy the needs that we have. Those support groups are very important. And I also have to mention that as much as we praise support groups as well can have stigmatization therein. So support groups of people living with HIV could also, like I mentioned earlier, could also have racism or sexism, homophobia, transphobia. Even within communities that look alike, there could still be that sort of discrimination in terms of social class and status, right? So as community leaders, recognizing that these things are very pervasive and creating a community that is very warm and welcoming so that anybody's differences or, distinctive difference is celebrated, another reason for them to be stigmatized or called out. We can talk about HIV without talking about U equals to U and all the legal and policy changes that can help to avert stigmatization. It could be policy changes that are punitive for discriminatory acts. It could also be policies that that encourage EDI approaches. So encouraging people who are experiencing those level of stigma to be in leadership positions within healthcare organizations or those who are able to make policies, encouraging involvement of people of color or diverse groups within those organizations. And I'm not saying like make the only one black person or indigenous person in your team the EDI rep or the EDI director. I mean, can they be the special advisor to the president? Can they sit on the board? Can they even be president, right? Because sometimes even just like forcing them into that box of EDI rep it can make them feel boxed into this is the only thing that I'm known for, this is the only thing that I can do. And so it limits their ability to spread their wings and go into like advance into other ways that it can help their community. Or like the one thing that happened during COVID and with the whole George Floyd issue was something called health equity tourism. And that was where like there was a need to have information and research on things related to health inequities. And so there was a lot of call for like grants and papers and research. And people who didn't feel comfortable or who weren't well versed in health equity scholarship were venturing into that just because of it's a hot market right now. Like there's a chance that this can be funded. And for example, maybe the CAHR has a call for funding on indigenous health, right? I know very little, or to the extent that I can support indigenous health is based on me being a minority, but I cannot lead a project on indigenous health because I would need that kind of support, and I would not look for the indigenous person in the community to just like be a collaborator or just acknowledge them on the paper, right? They have to be either like co-Is or co-PIs because I cannot do this work on indigenous health alone, and so that kind of like can also help to perpetuate stigma when you have that sort of health equity research tourism. And I feel like I'm sorry, I could go on and on, but it definitely requires just very multifaceted, very just multi-pronged individual systemic level changes that can occur to help to reduce stigmatization for different people. Thank you.
Thank you. That multifaceted piece is big. Christian. Public health messaging is an important piece of the puzzle when it comes to HIV prevention and treatment, particularly the message behind undetectable equals untransmittable, or U equals U. This is an evidence-based message stating that people living with HIV who are on medication and maintain an undetectable amount of virus in their blood can lead to a long, healthy life and feel confident of not passing HIV onto their sexual partners. How do we ensure effective uptake of the message across the diverse identities of all Canadians?
Yeah, thank you so much for the question. I think, just as how Donald had said, the pronunciation, is it PHAC or FAC? That still remains a history. The implementation and uptake of U equals U, I recognize there's still a lot of work that needs to be done in Canada. You're right that just science has proven that undetectability and virus suppression really prevents the transmission of people living with HIV. But then, in terms of being able to gain treatment and maintain, virus suppression is the core issue we're looking at. I was very privileged to have been able to lead a conversation with the partners from PHAC on the renewal of the STBBI framework for amongst people living in HIV about 2 weeks ago. And we have heard loud and clear that if people are not gaining access to services and care, talking about viral suppression or undetectability is not always beneficial. So, just want to echo and Emanuela's comment about being able to address also structural racism, right? When we look at the PHAC data on, the 1990 targets, we know that within indigenous communities and the ACP communities, the testing and also the viral suppression targets are low, and that also is the same for people who inject drugs as well. So being able to actually, I would say, in a concise way, is all the communities, all stakeholders need to work together. We have, public sector partners here today holding this panel. We have scientists, researchers. I'm a person living with HIV and a community activist. We need to solve this puzzle. This puzzle has not, we're still working towards it day by day. I think through collaboration, through, intentional listening, through careful and planning and doing it strategically, I think we can reach there. This response, I think, the conference, we have placed a lot of attention on people living with HIV who are aging. And, as U=U are able to support people to live longer and healthier lives, we also need to look at the other, systemic and structural barriers facing people living in HIV across the lifespan, from youth to, the elderly. How are we actually talking about testing, prevention, across the age range? I've been so privileged to have met, people living with HIV and activists in their 70s who are attending this conference. And, it's inspiring, yet also I know it's challenging because they're, impacted by chronic pain. They're impacted by social isolation and whatnot. I don't think there is a blueprint to how different communities would adapt, translate the messaging of U=U. At the CTN meeting earlier this week, we heard, from community members iterating that, access is key. And I do think if, there are opportunities where key stakeholders, key messengers, people with power and influence within certain communities can actually give U=U another chance. Perhaps, the implementation within Canada was a little different than how, it was implemented in the US. In the US, there's a lot of strong ACP women who actually advocated for U=U. The response is very different from, how U=U was uptaken here. I think, the government of Canada actually took a leadership position back in 2018 when it publicly endorsed U=U. And I think, since then, last year at the AIDS conference in 2022, Canada also, alongside with the US, co-released the multinational call to action on U=U. Those are, policy documents that I am proud to say as a Canadian that the government of Canada has, taken positions on. Yet, within, financially constrained environment, I would also encourage funders to really find ways to work collaboratively across all jurisdictions to fund the health of people living with HIV, because as HIV goes off the policy agenda, we still have a lot of issues to consider as we age. We still need to promote testing, and now we're doing self-testing, which is great. That's the first element that if we're going to get people on U equals U, we need to ensure that people know their status. But then, we have a broken healthcare system where not everyone is getting on treatment. And then after that, we still need holistic wraparound services to ensure people stay and remain on treatment. And I just want to also note that, perhaps one way for communities to, embrace U equals U is look beyond it as a biomedical messaging. In my role as one of the North American NGO delegates to the UNAIDS Program Coordinating Board, the community actually worked really hard to present a report that stated the health equity values of U equals U. So if we can think of U equals U as a multimodal, multidimensional tool, so there are specific communities that are not getting the health infrastructures or treatment access. How can we use U equals U as an argument to advocate for the expansion of these services? So I would really, love, the whole sector to really think about how we can also take some of those decision points from the NGO report to really frame U equals U as a health equity strategy that's achievable and realizable in Canada as well as globally. Thank you.
Thank you, Christian. Alexandra, this question's for you. It's been over 2.5 years since Canada approved the first HIV self-test, an empowering tool that allows people to access HIV testing where they want, when they want, and in a private and confidential setting. What positive impacts have these innovations had in the communities that you're serving?
It's true. It has been 2.5 years since the test has been approved, but I want to acknowledge Dr. Nikki Pantpai's work in this area since at least 2013. And it's actually been my experience that behind every device is typically a woman who's been using it for about 5 years prior to approval. And it has the potential to empower people to test where and when they want, it's true. But I think that's also a privilege to be able to do anything where and when you want. For where you really need to have access to safe space that you're comfortable in. And for when I know that I wanted the test for COVID every time I had a tickle in the back of my throat, but was that the best use of the device? Should I be thinking instead about what was the risk of me being exposed? How long ago? What are the implications if I have a positive result? So instead of providing people with an opportunity to test whenever they want, it might be helpful to give them a tool so that they can decide for themselves, is this the test that I need to use right now? So that's been a really interesting part of growing Get a Kit. And so about 1/3 of the users who access self-testing through Get a Kit tell us that they have no prior HIV testing history. 23 people have come back to us and said that they had positive results, and 100% of those people have been linked to CAHR. This shows that there's a need and that there's uptake, but this wasn't because of the self-test. This is because we put a system in place to support self-testing. When we think about how this applies to folks that we thought would need the test the most, we've had to make a lot of adaptations to the system. So we know that when we were talking about and getting excited about approval, that this would be a really ideal device for people in rural and remote communities, people who use drugs, people who experience homelessness, and people who, for whatever reason, can't or won't access traditional healthcare settings. And that's been largely in part working closely with partners. So we've been able to develop curbside pickup for people who don't want to have the kit delivered to their house. We've reduced the registration process, but maintaining that self-assessment component that we think is so important. And we put together a separate portal for people to be able to let us know about their result, even if they didn't get their kit from us, because we believe that linkage to CAHR is really critical. in the last 6 to 8 months, we have been having a lot of conversations with people, and the unfortunate thing is that there is a lot of hesitancy to talk about HIV and HIV testing. And so much of that can be because of stigma, of course. And there is another part of it where people are genuinely worried that they don't have the information or that they're going to say the wrong thing. So the element of training and support is also just as critical. When we, sorry, I feel like you guys all had phones on your laps and nobody gave me that memo. I had notes. Okay, so when we think about this too and when we implement, we really try very hard to make sure that all of the supports are regionally specific and that everyone feels comfortable. We want to make sure that there's an open door, not only for the people who are testing, but for the people who are offering the test. You have to consider the environment that this is being delivered in, the self-test is being delivered in. There's burnout, there's high staff turnover, there's an opioid crisis, there's a housing crisis, the price of food is going up. Everyone is having to manage all of this, and we can't think that we exist in a separate space. That all impacts us as well as implementers. So there's a positive spin on this, though. The positive part for me really is that the self-test is very fast, and it really doesn't give us a lot of time to not deal with all of these issues. And so when we've been implementing, we've had to address, and we haven't fixed it all, but we have had to acknowledge and address all of them along the way. And the other important part, too, that I think is really encouraging, and we've heard throughout this conference, is that a lot of this work is being done right now. So it's not like we're starting from zero. And Christian and everyone else will probably agree that we just need to work together to make sure that we can incorporate it all into one initiative. And eventually, when UNAIDS announces that it is 100, 100, 100, any kind of lighter or faster device will really only reinforce how important the rest of those components are. Thank you.
Dr. Daryl Tan, together with the expansion of treatment as prevention, PEP and PrEP, has helped to reduce HIV incidence worldwide, but access isn't universal. What are some of the barriers to access, and how do we begin to overcome them?
Thanks for the question. It's obviously, like all the others, it's an enormous question, and so I'll try my best to just throw in a few insights related to some of the evidence that I think we've gathered in this country, and then I'll hone in on, I'm going to get two specific things that I think the question was what can we do, and literally we, all of us here can do in the next couple of minutes. So what needs to be done? Well, there's a lot of data that's been collected already to understand the processes of what gets in the way of access to something that as seemingly simple as PEP or PrEP, but it's of course much more complicated than just filling a prescription and taking it, right? There's a whole cascade that many people have conceptualized and built that we've adapted and used here in Canada as well to better understand the PrEP cascade in gay, bisexual, and other men who have sex with men in this country that I'm going to use as an example. This is a lot of insight that comes from this project that we've called PRIMP that's co-led with Mark Hall, and Daniel Grace has presented some work on that, from that project here at this conference, Oscar Pico and others. And I want to also put a disclaimer that that's specifically about that population. There is a complete dearth of work on PrEP implementation in other populations that are very much needing and deserving of PrEP services, such as cisgender women, such as people who inject drugs. We really need as a community to fill those gaps. But what I can speak to knowledgeably about the work that I've been involved with is from PRIMP. We know that there's lots of barriers that get in the way of that access, and it starts at the very beginning. We have people who do not even know about PrEP in this era, right? Joe Cox from the Engage study has published a paper looking that in our 3 largest cities, Montreal, Toronto, Vancouver, in this country, even among this population, GBM, where there's been so much effort to amplify the PrEP message, 5 to 15% of people in that study had indicated that they had not heard of PrEP. How can that possibly be? We are failing even at the very, very first step. Even among those who do have a health system that takes the effort to recommend it to them, we've been trying to build that out through the PRIMP project, we have a lot of folks who say no, thank you, at that first offer for lots of different complex reasons, intrapersonal, interpersonal, structural, social, institutional. But some of the common ones are people having challenges understanding HIV risk. That's a common thing in health and medicine we need to work on. But other ones have relevance to the 2 things I think we all need to do. One of them is people tell us, I can't afford it. People also tell us, I don't think I want to do that because I'm afraid of the side effects. In some of the other studies that we've done through the PRIMP initiative, we've also learned that sometimes people do succeed in eventually getting on it. There's a few steps that tend to be not as huge in terms of gaps in the cascade, but then they may not be maintained and they may not persist on PrEP, which is also really important if this impact is going to be sustained. Some of the reasons that folks kind of fall off of PrEP sometimes, despite having a continued clinical indication for it, relates to things like stigma, which my co-panelists have all spoken about. And relates to things like they tell us that the first interaction that they ever had with a healthcare provider when they sought PrEP was not positive. That the provider wasn't culturally affirming and appropriate. They were not knowledgeable enough. They had to refer the person on. It was a struggle to get onto PrEP. These are things that contribute to people's willingness and ability to continue on it. And I think there's a lot of lessons in there. You talked about innovations. Yeah, we can innovate at all those steps, and we don't have time to get into all of that right now. But I will say that two pretty simple, not that innovative things that we absolutely need to do are cost related and social marketing related. So on the cost front, I mean, if people cannot afford the drug, it stops right there. And people, even in settings like British Columbia, Alberta, Saskatchewan, PEI, there are some jurisdictions in this country where PrEP is truly universally available. The federal reimbursed drug programs do also reimburse fully. Even in those settings, we have people tell us, no, I don't think I can take PrEP because of the cost. So we're not even getting the message out that it's free, for goodness sake, right? In the other provinces, we're right now on unceded territory, the Huron-Wendat, where this drug requires an outlay of cash from the user, right? Health is a human right. If health is a human right, how can we not make it available in a country like Canada? We're so proud of our health system. Cost is a fundamental barrier that we all need to overcome. And another shout out to Patrick O'Byrne from Ottawa, who presented some data earlier this week in the PrEP RN program in Ottawa, where making PrEP available without a financial barrier led to increase in uptake, drops in HIV incidence in that city. So we need to advance the discussion on making this universally available coast to coast to coast, as we need to do for antiretroviral therapy, as we need to do actually for pharmacotherapy in general. We need universal pharmacare. And the specific thing that we can do in this country, all of us, I should say, those of us who have the privilege of doing so, is to vote. These are policy discussions that are happening in our political system right now, and we have a role to play in that, let alone the hard work of doing the advocacy to make this a policy priority at minimum for antiretroviral treatment and prevention. So cost is one big piece. The other big piece that I think we can all literally participate in is amplifying this message, doing what we call social marketing, doing what we call demand creation. You know, we've just presented a systematic review that's in progress about PEP and PrEP to inform our PEP and PrEP guidelines in this country. There is a ton of data out there about just how safe and efficacious PEP and PrEP in particular are. Hundreds of thousands of human beings around this planet have volunteered their health to participate in clinical trials and cohort studies to demonstrate this to be true. It is true, and we are failing, I think, as a country to amplify that message. It is not something that you hear about. Even in our big cities, I like to share the anecdote that if you take the public transit in downtown Montreal or Toronto or other settings, you don't hear about PrEP, you don't hear about PEP, you do hear about HPV vaccine, you do hear about COVID vaccine, you don't hear about PEP and PrEP. That is despite this being a global public good. That is, the few times that you do hear about it, the anecdote is that it comes usually from a private clinic or a private pharmacy. So how is it that our public health authorities, all of us in this room, are not loudly amplifying this message? Draw the comparison with COVID vaccination. It is unequivocally clear to the public that public health authorities support this, that we promote it. Everyone talks about it. It is clear that that is the right thing to do. And I think if we push out that message, we can deal with a lot of the barriers that we've been talking about. We can help to unpack stigma by saying loudly, this is a positive, healthy, safe choice. We promote it. Everyone should learn about it. We can deal with that 5 to 15% gap of people who don't know about it. We can address the concerns that people realistically have about side effects, about it not being effective. We can deal with that gap that I mentioned where the first provider the person seeks PrEP from doesn't even know what it is and can't meaningfully address that need. We need to be doing that. All of us in this room, our conveners today, the Public Health Agency of Canada, I think can do a much better job of that as well. I'll point out that our framework for action on STBBIs up till 2030 doesn't really put PrEP front and center as a major initiative that we care about, and I think that is not that innovative a solution that we can really, really implement.
Thank you. We're going to move into a group question now, so feel free to chime in, any one of our panelists, and then we're going to ask for some questions from the audience. Priority populations of HIV response are often considered difficult to reach, as traditional engagement methods don't always meet their needs. How do we go about adapting the innovations previously discussed to work for different populations, and what does that look like? Christian?
Can I jump in? Okay. First of all, I think, before we actually approach specific communities, we actually need to look at, what may be some of the policies that are hindering, creating barriers for key population groups in engaging in, be it HIV testing or treatment or care. So, with the criminalization of people living in HIV, the continuous, kind of process in terms of the judicial review, I really hope that, our public sector partner can inform their Ministry of Justice colleagues that, the criminalization, the continued criminalizing of people living in HIV is really countering the work of the Public Health Agency of Canada. And beyond the criminalization piece within specific key populations, also protecting the human rights of people who use drugs, sex workers, and ameliorating the kind of support that people who have been incarcerated as they exit the prison system, if they require HIV treatment or support services, or be it other types of support regarding substance use, are critical. I really appreciate Daryl kind of talking about needing to heighten the visibility of PrEP. I would hypothesize also that I think Darren says there's actually a very few people who knew about PrEP, and I would say actually within the general public, I would think even less people know about U equals U. So how can we actually change that? I think one of the kind of suggestions, recommendations from myself and also the community is there a role that Public Health Agency of Canada can really play? Because the promotion of HIV knowledge, best practices has always been pretty siloed. We're here talking to ourselves, and hopefully next year we're not having the same conversation. But learning from what we know from the COVID pandemic is when there's public endorsements of PSAs, people do go get vaccinated. How can we actually reignite this conversation around HIV? Be it whether you're HIV positive, negative, or you don't know your status, how can we encourage you to get tested? I think in terms of social marketing and demand creation, that's great if you already know what the needs or the priorities are for specific communities. But in terms of furthering the promotion of U equals U, because of the needs of different communities are so varied. I've been kind of saying it a few times, and I think we can hopefully look into this. Is besides holding stakeholder dialogues with specific communities, is utilizing kind of evidence-based approaches like crowdsourcing. That's been demonstrated effective in testing campaigns in China and amongst youth in Nigeria, and also in the US amongst ACB men populations in the uptake of self-testing. So why this is important is because we actually need to engage the communities as we begin these processes. So I think a lot of you understand the principles of community-based research, the benefits of participatory action research, but we need to kind of step it up and see how we can link these into creating, effective kind of social marketing campaigns. And one way to do it is through, crowdsourcing. So those are the few comments I would like to share. Thanks.
Thanks, Christian. Daryl?
Christian, totally agree with everything you're saying. I'll say a couple things about how we can approach this that start with how we frame and have the conversation, first of all. I mean, I think the question was phrased in terms of, populations being hard to reach. I was very compelled earlier this week at a meeting of our Canadian HIV Trials Network, the CTN, where I think the project that you were speaking about earlier, Emmanuel, was highlighted. Dr. Sophia Bartlett from the BC CDC in Vancouver was speaking about a project about social prescribing of cell phones, which I think is a really great example of innovation to help improve access to services. In that case, it was hepatitis C treatment, but similarly applicable to HIV and STBBI management more broadly. But in her framing of the whole discussion, it was really valuable how it was described not as a population that's hard to reach, right? From whose perspective is this is the whole dialogue being had? And rather, it's incumbent upon us as parts of the system to think about how our services that we're building are the ones that are hard to reach. And so how do we improve the systems that we build? The social prescribing of cell phones is a great idea, and a great example of that. And I think there's a million other examples, right? We've just been at a conference where I want to commend CAHR for the last several years for having a session that's all about key populations and all about centering the perspectives of community voices, just as Christian was saying needs to be done, so that communities themselves can advocate for themselves and speak about what their needs are and propose solutions that will work in those specific groups. I'll finally also call out, Cécile Tremblay did a beautiful plenary the other day where she pointed out that in our preparedness for this pandemic, that pandemic, the next pandemic, the problems are pretty darn fundamental. And we can talk about our services being, populations being hard to reach. They're not. It's our services that are hard to be reached by folks, and we need to improve that. But there's also fundamental structure and social problems that I know are enormous, but we need to continue to frame the conversation in terms of the importance of addressing unstable housing and poverty and structural racism, these forces that we know conspire to make our services the things that are hard to reach.
Anybody else? You want to chime in? Sure.
Thank you all so much. I would also like to add in terms of testing and prevention strategies and hard-to-reach population, I think that in the development of these interventions, that is very important to have these communities that are considered hard to reach involved from the ground up, right? Like you don't, and I think historically from the history of HIV, it's always been something that was tagged as like being associated with a particular population of gay men. And so a lot of the times with interventions and things that have been developed, starting from there, it usually has such a focus on that population, and then they start to invite other unique groups, indigenous people, women, and all of that, right? But it's very important that starting from the creation of these strategies, these interventions, these medications, that you are listening and you're inviting the voices of these populations to make sure that whatever intervention it is, whatever medication it is, that is culturally appropriate, or it has all of this, it has all of their perspectives in mind. I lost my other train of thought, but it will come to me. Let me see if I remember. Yeah, I was just going to say as well, yes, it came to me. So in terms of research is another good way to educate community about the importance of being involved, whether it's in more research to develop interventions or teaching them, like raising an awareness of the importance of being involved with this sort of interventions. I remember that when I started my research, it was very, very difficult for me to connect with the community because obviously, and the one thing I was hearing is that we've been having these conversations for such a long time, like they've been collecting this data for several years. what has been done with it. Like, is it every time we have to sit and talk and talk about our trauma and every single time, but we haven't seen any change yet, right? So they want to see that, like, you are not just sitting and I don't know, like rattling in the traumatic stories of people, and that's something that you're actually using those stories to do something, right? So thinking about knowledge translation approaches that are culturally appropriate, where they can see that, okay, this thing that you've shared with me, I've brought it back to this research team, I've brought it back to the government, I've written this paper about it, it's been published, it's out there, this is what you need to know. Like, this is what has been said or what can be done, right? So thinking about knowledge translation approaches that are culturally sensitive and appropriate, so that they feel like you are not just exploiting data or exploiting them or just taking data from them just to grow your own scholarship or CV, right? And you're actually putting all of those things into action.
Great, thank you. Do you want to speak to me? Right? Sure. Yeah.
Just to add to what my co-panelists have been saying as well, like, I think that I was going to say the thing about the hard to reach. I read an article about, it was about education, and this person was writing a first-person perspective, like, I'm not hard to reach, I'm at home, where are you? And I think that that's so important. And I also think another element of hard to reach is, like, who's prioritizing HIV? Like, that's another part of the conversations that I've been having lately. A lot of people, it's the low perception of risk, but it's just not a priority right now, when there's everything else that needs to be dealt with. And so it really does take multiple interventions to be able to have a big effect. And this means that when we are listing out all the other, like, social determinants of health, housing, poverty, all these things, that might not be something everyone in this room can do, but it would be helpful maybe if we have more deliberate connections with the people whose focus that is. And I've found it really amazing, because it's an odd hobby of mine to learn about people's informal testing pilots and initiatives in regions that don't necessarily make the peer-lit reviews and all the journals that happens. There's a lot of sort of, I don't mean patchwork and makeshift, but I just mean it's people in a room together who decide by themselves that this is a priority, they connect, they collaborate, and then they do the thing. Like, and it just stays in that area. So when we talk to different groups about HIV self-testing, it's great to spend a half hour to say, like, 3 years ago when things were open, were you doing a pop-up testing event? How did that go? Like, what would you have done differently? Like, all that stuff really helped us with implementation because it was done. We didn't have to discover that for ourselves. But the idea of hard to reach too is really, it's really important that it's not hard to reach. We just don't know enough about it, and we have to ask questions, and we have to be willing to integrate that into our processes.
Thank you.
I would just love to I would love to jump in very quickly. I think within U equals U, the hard to reach community is actually healthcare providers. So many of them actually do not know about that. All the allied health providers, nurses, PTs, OTs, PSWs, they all need to be trained and retrained, right? So how can we actually penetrate that really hard to reach, maybe like super busy, maybe they would say they don't have time to re-educate themselves, but I think it's an ethical responsibility that they get updated about, the HIV innovations. I would also say, I agree with all of my fellow panelists, priority populations are not hard to reach if you actually know the people. We are there, as Alex says, we're at home, pay us, invest in us. There's a big sizable population of people living in HIV that are living better, being able to returning to work, be it part-time or full-time. I know we are currently in an economic, maybe bordering a recession. And how can we actually, have governments invest in, people living in HIV so we can really drive the response? So that's all I have to say from.
Great, thanks, Christian. We're gonna move on to the next question here. This is their last question before we're gonna open it up to the audience. So really briefly, maybe one point here. We've got some really good information. And I know there's a lot more to be said. But from a research lens, so you guys can line up at the mics if you like and think about your question. But from a research lens, what are the strategies for incorporating intersecting identities and experiences? And what are some concrete steps for adapting existing innovations among different communities?
I'll try to give a brief answer to that. There's so many ways, again, to answer that question as with any others, the others that we've been speaking about. So I'll choose to focus in on a very specific, narrow piece because it's a very concrete thing that one can do, I think. And I think it starts with making sure, as researchers, we have the information. We collect the data, and we collect the data in an appropriate way. I can't tell you the number of times that in some of the work that I've done with amazing collaborators, we've submitted a project to the RB, and we wanted to do comprehensive socio-demographic data collection in order to understand intersecting identities and how people identity and their affiliations, their communities. And we were given letters back from research ethics boards saying, it's not appropriate for you to collect these data. Don't do this. And I feel like that is plugging our ears to people's need to identify and tell us about their intersections of identity. So make sure, I think that the simple, concrete suggestion, it's a narrow piece, but is to make sure we collect those data. Within the CTN, we had postdoctoral fellow Tin Vo, he's actually a postdoc of the Queer Health Hub that everyone should know about, that did a project to look at how we've been collecting socio-demographic data within CTN studies in the last 50 years, and there are some gaps that were identified. People sometimes conflate sex and gender, for example. We're not asking about ethno-racial identities in the most respectful way, certainly not always about indigenous identities in the most appropriate way. We have lots of other categories in our surveys that literally others people. So there are best practices that we can learn about, and that's one very narrow but useful, I think, way that researchers can contribute to making sure we address these identities.
Absolutely. Anybody else want to chime in on? Oh.
Okay, I can go ahead. Just speaking about from a research lens, I totally agree with what he has said. I also just wanted to point out at another thing in terms of intersecting stigma. I can't count the number of times that I've read papers that were conducted in Africa, or you don't do research on people, you do research with and for people, right? And so you read these papers and there is not a single one Black person listed in the authors, right? Maybe sometimes they might acknowledge other individuals who have been part of that. And for me, I feel like somehow that is just very, because this work would not have been possible without those people. Even if they don't have the academic qualifications to contribute to the paper, the local nurse who helped you talk to the people in their local language, she was very instrumental to this study. Just having her, maybe even just like giving her the opportunity to be part of the manuscript helps to, with that exposure, right? The next time a person reads that paper and they see that name, they start to look for them. They see, oh, this person is a director of this community. Let me try to find them. And that way, like, it helps to grow that sort of support network, right, for people who might have things in common with that community. The other thing I wanted to mention in terms of research and just like working with peer navigators is ensuring that we also have diversity when we're working with peer navigators. I had a very interesting chat with a guy here yesterday. He was in, oh, he's right there, Arthur. He does a very amazing program called HYPE, where they match. So it's an adherence improvement program, right? So they match young people who are very adherent to their medication with other young people who are not adherent. It's like a one-to-one match. And I thought, wow, that's really amazing, because most times when someone is newly diagnosed with HIV in the clinic, right, the peer navigator that they call into the room sometimes might be like maybe a young Black girl who's just been diagnosed, and the peer navigator who comes into the room to speak to them is like the tall, white, gay male, or just a different, totally different person that they cannot relate to in any way. So it helps to have that sort of diversity when we are selecting peer navigators, to make people feel like, oh, there's somebody who looks like me, who acts like me, who behaves like me, that shares the same problem, and like people connect more with their vulnerabilities, to be honest. And when you create the opportunity for that, it really helps with like improving culturally specific or safe ways for them to like get better in terms of their HIV.
Great. Thank you. Adrian, we're going to move to the audience for a question here. I know you've been.
Manuel, I'm so happy I met you. Thank you very much for the plug. Until Christian got around to it, what was missing for me in the entire conversation was the inclusion of peers. Right? This is how you reach the 10-10-10. By investing in peers. And it's not just taking our expertise and running with it, it's giving living wages to people to do this work, to go out there without impacting their ability to access their medication, because in Ontario, it will get deducted from their ODSP, then they're on Trillium, then there are what they call deductibles. It's ridiculous. It prevents PHAs from working, the system in Ontario. So peers truly do make the best interventions. I mean, there's multiple research projects that prove this. My own program, HYPE, is based on peer navigation. It's HIV youth peer engagement. It's peer-to-peer conversations about adherence, about navigating the healthcare system from a racist perspective, from a sexist perspective, and so forth. And we found that the young people in our program, they help each other navigate, and the number of kids lost to care has decreased in Ontario because of this program. Yet, there are kids across the country, in Quebec, they're clamoring for it. In BC, they want it. In Saskatchewan, they want it. But though I'm funded by FAC, and I'm very grateful, but like, the model works. Like, let's expand it. Let's share it. Why do we keep stuff so siloed? And I don't know, there's so many hoops to jump through when you have something that works, because you need 8,000 research programs to make it, to prove it's working. Well, you know, we don't have time. We don't have time. So thank you, Christian, for including peers in your conversation, and thank you for this wonderful conversation on the whole. But it has to include people living with HIV and people at risk for HIV, leading the messaging into their own communities.
Thank you. Another question, Dylan?
So my question is based on knowledge translation. What are strategies to use knowledge translation as a means of advocacy? Advocating to governments, to regulating bodies for professions, to educational institutions. Is a lot of research using their results to go to these places and demanding policy change? And how would you do that, or what would be your ideal for, say, expecting the College of Social Workers to do mandatory training on HIV sensitivity or on HIV support?
Can I answer this? So I've learned very quickly working with Patrick O'Byrne that publishing findings is really important. It was not something that was as critical and central to my previous role, but now it really is so important. Like if you have a project and it's working, being able to publish that in a journal is great, because when you do letter writing, and we've done a lot of it, you have a reference list. This isn't, like, this is for us specifically in working out of the University of Ottawa, but I can say that it's getting results in a way that I didn't think would. We're having great conversations with a lot of wonderful people. So that's the policy part. And then the other end of it, I think it's connecting with partners who are already having conversations, already putting up posters, already doing the work, and then working with them to say, okay, what does this information mean to you and community and clients, and how can we tailor this messaging so it makes sense in this context? And in terms of the colleges are so tough, and to connect and to create change in clinical behavior, like we know that getting anti-stigma work in schools is really critical, and so having connections there is really helpful if you can have a guest lecture, or if you can have another talk, or you can organize something. Now, can one person do all three of these things? Unlikely, but I think that's all the more reason for us to try and collaborate more, because it does take different strategies to reach every part.
Thank you.
Yeah. I think, you know, just building multi-stakeholder relationship is a great approach. So, you know, you have the scientists, you have the community, you have hopefully, you know, someone working within the public sector who can be, you know, a messenger or supporting or guiding how you can approach to decision makers. I think, you know, we can use the evidence, we can convey our views. If all fails, follow what activists did at the AIDS 2022 conference, storm to the stage. So yeah, make it newsworthy, get people talking about your issue. So that's my recommendation.
Thank you, Christian.
Just quickly.
Really quickly, sorry.
So I'm part of a group called Black HIV Manifesto, right? And it all started with us just like being tired of not having any specific data related to Black people so that we could work with. And the strategies that we've used, we've just literally written open statements and written manifestos and written documents and emails that we send out to these organizations. We've reached out to Katie, we've reached out to PHAC, and chances are like you're going to get audience, right, in terms of like creating an awareness of what your issues are and what your demands are in terms of your community.
Thank you. We have another question over here.
Hi. My name is Patience. I would like to talk more about people of lived experience. I'm a community support worker. I have so many hats. And since I came to Canada, it's almost 16 years now, I feel I'm still a newcomer. There's so many challenges people living with HIV are facing. And whatever strategy is done here in Canada, I feel the public health of PIAC should engage people, community experts of living, community experts of lived experiences. There's so many challenges people are facing, especially those with the language barrier, they're left out. In our community, we have a program called Sister Chat and Brother Chat. That's where we engage people in their respective languages. And what we need from the government, we need people of lived experience, community experts to be trained. We need trained interpreters. We need trained peer navigators. We need the government to sit down with people of lived experience to listen. Listening is a tool that people are missing. It's an important skill. Communication and listening. That's what is lacking in our community. And people are dying of AIDS. Till today, people are dying of AIDS. We are not expecting to see deaths at this century. People are dying. There's a lot going on in our communities which no one knows. We have people who are struggling with mental health. Newcomers, as Black people from Africa, they're coming from war-zone countries. Coming to Canada, they're carrying that PTSD from where they're coming from. They are homeless from where they're coming from. When they come to Canada, they don't have any kind of support. They're struggling because of their HIV diagnosis. Before coming to Canada, it's mandatory to have an HIV testing. And when people come here, no one listens. And the only experts who can do this work and also engage in supporting people is people as community experts with lived experience. We need to hear from them and also implement whatever project we want to run in our organizations. With that collaboration, again, we are not going anywhere. We really need to, if we really care, especially with care, I would like to talk more about the healthcare. Healthcare, people of lived experience are struggling to engage to care. Like for me, I don't access care where I live. I've been discriminated so many times. And if at all I didn't engage myself into the community, I was not going to be here today. At one time, they wanted to test me for Ebola. Because I'm Black, living with HIV, they assumed that I had Ebola. We need to train healthcare providers. You know your theory, we know our practical. We should combine the two if we really care and help people. Thank you.
Thank you. Hey, this will be, excuse me, this will be our last question. Go ahead, you got the floor.
Bonjour. Malheureusement, je parle juste en français, mais je me nomme Jonathan, président du dispensaire. Je suis un travailleur du réseau de la santé, puis ce que je m'apprête à faire là, c'est quelque chose d'important pour moi. Je suis une personne vivant aussi avec le VIH. Donc, on parle de stigmatisation depuis tantôt. Moi, je travaille en première ligne dans un CIS au Québec. Et en effet, il y a beaucoup de chemin à faire pour la stigmatisation, que ce soit sur la PrEP, les personnes vivant avec le VIH. Je l'ai vécu moi-même pendant la pandémie, évidemment. J'ai eu la chance de travailler quand même avec des collègues compréhensibles, mais j'ai dû quand même en éduquer beaucoup parce qu'on est loin de la réalité. Le message que j'aimerais passer aussi, c'est tout ce qui se passe dans les médias. Tu sais, parfois, on a des discours je me l'ai dit, de certains politiciens ou certaines personnes sur des histoires, comme si on parle de Barbada, la drag queen. On a des faux messages qui passent en public et on a beaucoup de travail à faire sur la médiation, qu'on parle de Radio-Canada, TVA, tout ça. Ce n'est pas assez médiatisé si on veut se rendre vraiment à un objectif de 30. Donc, c'est un petit peu ça mon discours, pourquoi je voulais venir. C'est difficile pour moi parce que je pense que c'est la première fois, je vais dire merci à IDLP et la COC-SIDA de m'avoir ouvert un petit peu mon leadership, mais on a beaucoup de travail à faire encore. Ce n'est pas vrai que les organismes communautaires qui sont en train de mourir à petit feu peuvent éduquer toute la population et même nos CIS et CIUS au Québec. Je suis vraiment désolé, mais ça ne peut pas se faire. Il y a beaucoup de travail à faire. Les gouvernements vont devoir s'allier pour qu'on arrête cette lutte-là, tous ensemble, mais qu'on ait aussi des vrais messages médiatisés, que les gens puissent avoir des vrais messages clairs. Voilà.
Merci beaucoup pour le commentaire. Je suis complètement d'accord avec tout ce que ça dit. C'est vraiment dans le même esprit de ce que j'ai dit au sujet de notre responsabilité collective, mais aussi par l'agence qui nous a convenu aujourd'hui de promouvoir ces messages scientifiques qui sont basés dans les données, de promouvoir le concept de U equals U, de U égale U, et de la PrEP, de le traitement pour... et je pense que ça peut... même si on ne fait que promouvoir le fait que ces interventions existent, qui sont très effectives, on pourrait au moins avoir, je pense, un effet très important sur le problème de la stigmatisation. Parce que le problème, c'est que sinon, on est complètement silencieux. Et je crois que la solution commence là.
All right, well, I'd like to thank each one of our expert panelists here today. I'd also like to thank CAHR and the audience for their questions. And I'm probably in trouble, I went way over. Sorry. I wish you all the best. Thank you.
Moderating.
Thank you.